So we all know that orbit is considered to be a Pandora's box, and you can have actually surprises in the orbit. So it's a very straightforward presentation. We're not going to deal with normal orbital tumors, but those which actually mimics like inflammation and other disorders, and then it can be lethal, and you should not be missing in your clinical practice. This is an analysis of a large analysis of 2,480 space-occupying lesions of the orbit. And what they have reported is that, 68% were benign, but 32% of the lesions in the orbit were malignant. And most commonly what they found was, even among the 8 most frequent orbital tumor, non-Hodgkin's lymphoma. And lymphomas can actually mimic in different forms. Well, sphenoid wing meningioma, optic nerve meningioma, these are benign lesions. So among the 8 most frequent orbital tumors, lymphoma is actually topping the list. And you have to keep that in mind. So I'll just take you through few pediatric cases and then come to adult. So this child is from the remote village in the central India who was referred for diagnosis and management. In fact, 3-month-old baby girl, and it was diagnosed to be an orbital cellulitis in this child. And for 10 days the child has been having proptosis. Well, yes, there is severe proptosis, but it doesn't really fit into orbital cellulitis. The child didn't have any history of fever, and the parent says there has been a very rapid progression in 3 days. Okay, so this was how the child looked like when the child was born, and subtle proptosis happening. So this doesn't happen in an orbital cellulitis, right? Yeah. So you always need to ask the parents or the patient for previous pictures whenever they come with proptosis, so that you know exactly how the disease has actually progressed. So it was like a sudden proptosis, yes, orbital cellulitis infective, that's what we would keep in mind. But well, the child has started having proptosis as a baby, and this was how the child came into. So we went ahead doing an MRI imaging, and it seemed to be a very high grade malignancy. And why do I say it's a high grade malignancy? Of course, the rapidity, the size of the lesion in this baby, and you can see this central, it's an heterogeneous lesion. Heterogeneous means there are different colors in the same lesion. There is different component in the same lesion, and this is kind of very cystic kind of a thing. You see that? That means indicates that there is necrosis. And when does necrosis happen in the tumor? When there is a very advanced high-grade tumor, where the tumor has grown out of proportion to the vascularity where the tumor can have, and then the central area goes for necrosis. So whenever you see these cases, you're really worried. Okay, so what we went ahead doing was to go ahead and debulk. It's very difficult to do the entire excision in this case, because you can see the lateral rectus is absolutely not seen. It is something arising from the lateral rectus, and in the presentation the child had an esotropia also. So well, we went ahead doing maximum debulking. One was basically for diagnosis and also to reduce the tumor load. We went in for a very rapid diagnosis. In fact, it was like a frozen section, because I was very curious, and the tumor was growing so rapid. So we went in for a rapid diagnosis, and it came out to be an orbital rhabdomyosarcoma in a 3-month-old. It's very young age for a 3-month-old to have an orbital rhabdomyosarcoma, and this came out to be a very high-grade lesion. So well, we do have international classification. All the protocols are in, and in fact, the child went ahead receiving the treatment, and still the child is on treatment. So the child has not completed the treatment. Yes, yeah. So this is yet another case, a 10-year-old girl, proptosis, rapid progression, diplopia, mild pain. Again diagnosed as a case of orbital cellulitis. Does it look like orbital cellulitis? Not really, right? Yeah. So well, was seen in a government hospital, and then they were kind of doubtful that it doesn't look like an orbital cellulitis, and this is how it looks like. There is so much of subconjunctival hemorrhage. What does that mean? That there is lot of vascularity. Whatever is growing has got lots of vascularity, and it's actually causing subconjunctival hemorrhage. Imaging was done, and this is what we see in the image. Okay, so you have this lesion in the orbit. What all do you see here? It's not only the orbit which is involved. You see this temporal fossa, it's involved. You see the cranial fossa, it's involved. When you compare the bone of the normal side, the right side and the left side, you can see there is some amount of hypersclerotic bone which is there. And also there is bony erosion. So whenever there is hypersclerosis and bony erosion, mostly it actually gives way to the diagnosis of a malignancy. So this is what we have always been taught, like even in our fellowship. Whenever you find a triradiate lesions, this is called a triradiate lesion. Tri, involving 3 spaces, all right? Neuroblastoma, PNET, sphenoid wing meningioma, plasmacytoma, leukemia, and lymphoma. This is mostly in the adults. When it is a child, you should always think of a neuroblastoma or a PNET. And well, we went ahead doing an incision biopsy, and it came out to be an Ewing sarcoma. So this is actually the panel of immunohistochemistry that we do, we go ahead. So it's just not like talking about sarcoma. We actually need to know specification of the tumor. In fact, we even do genetic markers now. So that is how things have progressed, and it also helps us to know what's the prognosis of the lesion, whether there has to be a deviation in the chemotherapeutic agents which has to be done. So this is the extensive workup, pathological workup that goes behind all these things. And in fact, bone marrow biopsy and PET scan was normal, and the child was lucky. So she went ahead, doing she completed a treatment, and for the past 3 years, she has been disease free. Now this child, you are going to give me the diagnosis here, okay? I'm not going to talk about this. I'll just give you the history. 11-year-old boy, history of fall, eyelid swelling, eyeball bulging. This case was actually referred as a case of retrobulbar hemorrhage to my oculoplasty practice, not to my ocular oncology practice, okay? Like whether there is trauma, whether blood has to be drained, there is retrobulbar hemorrhage, etc., etc. There is ecchymosis, and you can see, well, there is absolute severe proptosis in the left eye. Do you think the right eye is normal? It's not, right? There is some kind of fullness over there. Does the child look normal? What do you feel? I mean, yeah, even the cheek, right? So the cheek is full. The child is very emaciated. Lots of pallor. Can you see? Like, he's very pale. The child is very, very pale. So a child presenting like this, what would you want to do? Well, imaging, of course, I do have imaging for you. All right. So there is a large lesion in the left eye, and there is some amount of diffuse lesion sitting in the right eye also. So what would you want to do? Tell me the diagnosis. Peripheral blood smear, yes. Ultrasound abdomen, yes. So only thing that I did was to go ahead and do a peripheral blood smear. And why did Dr. Raksha say peripheral blood smear? Any resident? Leukemia, right? Yeah. So any ecchymotic lesion causing proptosis, you should always think of leukemia infiltration, or what we call it as granulocytic sarcoma. And this is what was seen in the peripheral blood smear. And that's all that we need to do. I didn't even go into the orbit to take a biopsy. Peripheral blood smear, diagnosis done. Patient was referred to a pediatric hemato-oncologist, but the child didn't make it. The child died due to the disease. So this is a very interesting case, where the child complains of on and off inflammation. Okay, so preseptal cellulitis, it comes, it goes. And this is in fact the child who came to the clinic. This was how she looked like. Then I was like, no, there is absolutely no. Then the referral doctor said, no, there was peripheral, there was some amount of preseptal cellulitis when she presented to me. I'm like, absolutely, it's so, there is nothing happening. And then I had to go ask the parents in their phone, how the child was. And this is how she used to have on and off swelling, and she was under observation. So well, whenever there is an on and off swelling in the orbit, there are 2 things that we would keep in mind. One is infections like tuberculosis can cause these kind of picture, and the major thing is histiocytosis, okay, like Langerhans cell histiocytosis, eosinophilic granuloma. So this is what her imaging looked like. There's a lesion in the orbit, and in fact there is complete erosion of the roof. Luckily, the dura is intact. It's not going inside the brain. So this is a large lesion. We went ahead. Curettage was done because there was a suspicion of a histiocytic disease, and it was given immediately, and then it was proven to be histiocytic disease. Maximum curettage. I gave an injection in triamcinolone acetonide. It's not a malignancy, okay? It's just a benign lesion, and immunohistochemistry proven to be eosinophilic granuloma. So it looked like a malignant lesion, right? There is bony erosion. So whenever there is a bony erosion, you think of a malignancy. But there are are benign lesions also which can present as a malignant lesion. In this situation, actually, eosinophilic granuloma and histiocytic lesions has association with chronic myeloid leukemia also. And they can have these lytic lesion in other part of the body as well. So a complete whole body scan was done, but everything was clear and she was doing fine. So this is how she actually looked like after 3 months. In fact, the bone formation also happened. She was free of the disease, the bone is back, everything is perfect with steroids and removal of the lesion actually. This is a very interesting case. So this was a 40-year-old lady. She is, chronic history of sinusitis. She has always been telling, sinusitis, and it's been like a very, very chronic history. And the sad part is there is a very, pronounced family history of cancer. Father with esophageal, mother with ovarian cancer, grandmother with ovarian cancer, and maternal aunt with ovarian cancer. So, when a patient walks in like this with a very strong family history, you are kind of thinking of something which is lurking around. And she's on steroids. When she stops the steroids, again, the lesion and the puffiness comes out. Although, it's not very, very clearly seen here, she definitely had a palpable mass in this area. And there is a lot of fullness over here, okay? So I was not comfortable. Any cellulitis kind of a picture, any periocular puffiness, which is on steroids, it goes away and it comes back, it definitely requires to be biopsied because there can be something which is lurking around. And then, she also had a mucosal polyp in the sphenoid sinus. So the working diagnosis, I really didn't think of a malignancies, to be very honest, inflammation, infection, because she also had a kind of a septal necrosis. The nasal septum was necrosed. So venous granulomatosis was in the high list, but it came out pathologically initially as Rosai-Dorfman disease. Well, it was not really fitting into it, but then we went ahead doing an immunohistochemistry because there was so much of doubt, lots of plasma cells, and it came out to be a very rare lymphoma, a natural killer T-cell lymphoma. And she also has systemic involvement. In fact, she had a nasal disease which was actually extending, taking long process and extending into the sac area. Her sac was fine and it was a peri-sac lesion. So very sad disease, and the patient didn't make it as well. So this was a case actually which happened during the second phase of COVID, where he's a diabetic patient, lot of orbital cellulitis like picture, was referred as a case of possible fungal disease, okay, mucormycosis. Well, it was not looking like mucormycosis because the sinus is absolutely clear. We all know that mucormycosis arises from the sinus, and then it goes to the orbit. Sinus absolutely clear, even the maxillary sinus, ethmoid sinus, sphenoid, everything was clear, and it was actually over here. And this was also a case of a natural killer T-cell lymphoma, and both of the patients didn't make it. It's a very, very aggressive lymphoma. Although they presented as an orbital cellulitis and an infection, it turned out to be a malignancy. Now, this patient was referred to me for dealing with the ptosis that she has in the right eye. She does have a ptosis, right? She was sent for a cosmetic, correction. But what is more pronounced here is that kind of a fullness. We usually don't see fullness in ptosis, especially in an acquired aponeurotic ptosis. You have a high lid crease. You don't get fullness there, right? Yeah. So it was not like fitting into, and I didn't want to go and do a ptosis surgery in the patient. The first thing that I did was to do a imaging. And this was what I found, a lesion which is in the supromedial orbit, closer to the bone is intact. Went ahead, did a biopsy, and in fact this lesion was this is actually a superior oblique tendon, and it was wrapping around the superior oblique tendon, all right? And this is how it was excised, and this came out to be again a lymphoma, very rare, a follicular helper phenotype. Unfortunately, in this patient, the patient had the PET scan was done, and she had systemic involvement, abdomen, para-aortic nodes, cervical nodes, and bone marrow biopsy was positive. A very subtle ptosis, very subtle periocular puffiness, but see the extensive disease that she has with a rare lymphoma. In fact, yeah, she was stage 4. She went ahead receiving all chemotherapy and she made it. All right, 50-year-old lady with eyelid drooping again, complete drooping. She was treated as a case of myositis, and this is how thickened her superior rectus LPS complex is. All right, yeah. So whenever a patient is kind of subsiding with steroids, but still not, she was treated as myositis, a little bit of resolution, and again the swelling comes back. In fact, this was a muscle non-Hodgkin's lymphoma. Okay, so they can also present like myositis. So role of biopsy in orbit has a very, very pronounced role. Whenever you are in doubt, go inside, take an incision biopsy and prove that is inflammation. Until otherwise, always think of these very bad lesions which is lurking around. This patient, last case, 52-year-old gentleman, bulgy eyes, recently noticed. He was diagnosed to have a sphenoid wing meningioma clinically, and this patient came for a second opinion. And well, I would also think of a sphenoid wing meningioma, right? There is again bony erosion over there extending to the temporal fossa, lateral area, and this is typically how it looks like. But well, in order to treat it, we always require a pathological diagnosis. So thinking of sphenoid meningioma again, I went ahead doing a pathological diagnosis, but that was again a surprise. It came out to be a lacrimal gland adenoid cystic carcinoma, eroding the bone from the lacrimal gland area and going into the temporal fossa. So I would just want to emphasize that. Yes. Yeah. Correct. So I actually didn't think of an adenoid cystic carcinoma at all. So the referral doctor also was a specialist. They had diagnosed sphenoid wing meningioma, and I also thought it's sphenoid wing meningioma. Since the patient came to me, he was willing to do a biopsy with me, and I did a biopsy, and it came out to be an adenoid cystic carcinoma. And this patient had, he is still alive, but he developed systemic metastasis despite the treatment, because whenever there is an extension into the temporal fossa and the bony involvement, always they have a very poor prognosis. But he's still alive, with a small lung nodule which is existing. Yeah, so yes, that comes to the end of this instruction course. It's just to educate you and raise the awareness of these lesions, which sometimes looks like very benign, even in eyelid, conjunctiva and orbit, but well, it most of the time masquerades. So keep all these things in your mind and your practice, and well, yeah, that's it. Thank you very much.